We do have Dr. Jay Harness here. He's amazing. I'll let him introduce himself, and that way he can get his talk going. But you do have a presentation, so do you need Brett to help share the screen?
No, can I, as long as I can share my screen here,
Right.
Peg.
Yeah, you should be able to share.
Yeah, in fact, there it is. Let's see if we can bring that up. And let me go to, uh, let's go to the slideshow, and there we go. Hey, everybody, Jay Harness. It's a treat to be here with you. Peggy, Brett, the others. You know how much I enjoy being with you this year. And I know the and I know the last couple of years I keep talking about exercise. Well, guess what? I'm going to talk about exercise again, but I've got basically breaking news for you here, okay? And I don't know what can I, Brett, what can I do to get rid of this thing up here at the top of the screen? Do you know?
I don't see anything. We see
Oh, okay, it's just
we
me.
see the
All
blue.
right.
Yeah.
Yeah, it's just me. So that's okay. Good. So anyway, yeah, what I've got across the top of my screen here is how to stop sharing and whatever. So my apologies. But I'm going to talk about a little bit about some breaking news that just happened last month at the American College of Surgeons meeting in San Francisco about nipple and areolar sparing mastectomies in men. Okay. Wow. Breaking news. Then we're going to talk a little bit about exercise and beyond, as well. This is a textbook that I put out about in 2017, 7 years ago, called Operative Approaches to Nipple Sparing Mastectomy, Indications, Technique, and Outcomes. My co-editor with this was Dr. Shauna Willey back east. Prior to this, and I'm sorry, gentlemen, but I've got to show some lady mastectomies right now, okay? Well, prior to making nipple sparing mastectomy a standard of care, this is what we typically ended up with. Long transverse incisions, the nipple areolar area removed, implants put in 1 or 2 stages, etc. And then following that, follow-up surgery to twist up some skin to look my nipples, and then some amazing tattooing to actually make them look relatively real. So the issue became, can we do this and have a better cosmetic outcome called an oncoplastic approach, oncocancer plastic surgery. And the idea is that with the newer mastectomies, nipple sparing, we're going to hide the incisions under the breast because they'll go away once you re-expand this area, and also maybe a second incision up in the axilla. So here's an example of a patient who had areolar sparing mastectomies because of some involvement of the nipple, which is quite unusual in women. And we could have done reconstruction on her subsequently, but she said, hey, I'm really happy with the way this turned out. Here's a lady pre-op, needed bilateral mastectomies. Here she is post-op. You do lose sensation, but notice the tremendous cosmetic result. The scars are hidden down here, counter incisions to help with the lymph nodes up here in the axilla. So cosmetically, when she gets out of the shower and looks at herself in the morning and says, you know what, I look whole and intact. So then the issue then becomes, can we do this in men? Because commonly what we've done in men is this sort of approach because the cancers were near the nipple areolar area, we would naturally remove the nipple areolar area, thinking incorrectly that that it would automatically be involved. And what we found historically, unless the cancer in men were straight underneath the nipple areolar area and even invading into the areola, that most of the time they weren't. So the aim of this study that we did at Stanford, and I contributed to as well, and several other institutions, was to, on a preliminary basis, and I want to really emphasize this is preliminary, can we do nipple or areolar sparing mastectomies in men and preserve sort of the cosmetic outcome? And as I said, this was just presented last month as a poster at the American College of Surgeons. The lead author is Marty Karen from Stanford. I'm one of the authors on this as well. And this is the whole presentation. I'll break it down in subsequent slides. So typically with men with breast cancer, they usually present as a mass. It's extremely unusual for men to present with a nipple discharge. And so the question then becomes, if mastectomy is the preferred treatment instead of breast conservation, in other words, lumpectomy and radiation therapy like we do in women, can we do a nipple-sparing mastectomy or an areola-sparing mastectomy? And the answer was, in our preliminary study, as long as there was no involvement of the nipple on physical examination or imaging studies, and we can they can present with a mass or nipple discharge. And then really importantly, we always do a biopsy in our ladies right underneath it in the base of the nipple. And as long as that biopsy is negative and not showing cancer, then we can continue and do a nipple-sparing mastectomy. And the biggest caveat of all was that we learned with our ladies, hey, the areola is just more skin, just different, and the nipple is too. Rarely do cancers extend up there. It's just another margin, meaning as long as there's no ink on the margin when the pathologist is evaluating the tissue and it's a clear margin, we can safely do it. Well, what about if it's close to the areola itself, partially invading? The idea here is we can take part of the areola, or if the inside or the nipple is involved, and save the areola. So these are highly selective cases. Again, the bottom line is here that the final margins, as assessed by the pathologist, have no ink on the margin. Just to explain, they put ink over the specimen on the outer surface and then look with the microscope and make sure under the microscope we don't have any ink on the margin. So this was a multi-institutional retrospective review of male breast cancers that underwent nipple-sparing mastectomy or areola-sparing mastectomy from 2008 to 23. Again, as I said a minute ago, that the indications were no tumor involving the nipple or areola area. Tumor characteristics, the treatment and outcome were all analyzed. Now, there were 15 males in the study, but only 14 had cancer, and one of them was my patient that I'll talk about down here. They ranged in age from 36 to 77. 11 underwent nipple-sparing mastectomies, and 3 underwent areola-sparing mastectomies. TIS is in situ breast cancer, which is not common in ladies nor very common in men. Although interestingly, nipple or in situ breast cancer can actually present as a mass, yet there's no invasion, or a T1 or T2 size cancer, lymph node negative up to some extensive lymph nodes. And of these 14 cancers, they were all estrogen and progesterone receptor positive and invasive ductals, except for these 3 in situ. 5 of the 14 were actually HER2/neu positive, which we can see in gene carriers. 3 of the 5 then underwent neoadjuvant upfront chemotherapy. And a BRCA patient who was one of these who had a nipple-sparing mastectomy on one side had a prophylactic nipple-sparing mastectomy on the other side. And here is my patient. And this was a story of a gentleman who came in to see me because of gynecomastia, the enlarged male breast. And naturally, I should ask men, well, do you have a history of breast cancer? And he thought for a moment and he said, well, you know, Grandpa had breast cancer. Really? No kidding. Anybody else? Oh, you know what? Uncle Joe had breast cancer. And I went, oh my goodness. At this point, I'm sitting upright. Oh, he said, oh, I forgot my dad had breast cancer. At this point, I jumped out of my chair. I ran down the hallway, grabbed a genetic counselor, dragged her by the arm into the room and said, test this man. he's got at least a 50% chance of being gene positive. And he was. And I said, you know what? You don't have cancer. Let's do a nipple sparing mastectomy on you as a preventative prophylactic mastectomy. And he's still alive 7 years later and had no evidence of any kind of recurrence or whatever. The largest tumor in this nipple sparing group was 3.2 centimeters. Again, they all had clear margins. Two of the patients had lymph node involvement, either N1 or N2, and also therefore had postoperative radiation therapy. So the talk that you just had, which Vanessa was really well done about radiation therapy, when you start taking out lymph nodes and adding radiation therapy, Peggy, then the odds of the lymphedema in Brent really go up, okay? And so watching for lymphedema in men is really important. And when we reported this a couple of weeks ago in San Francisco, at 8.8 years of follow-up, we've had no recurrences. So again, all patients had clear surgical margins. We had no ischemia, meaning no blood flow complications to them, and no patients desired immediate reconstruction. So here's what the typical unilateral mastectomy looks like with a transverse scar. I grant you these areolas are pulled off to the side a little bit with this gentleman's arms up. But again, these are pretty decent looking areolas. You could add tattooing to it and really get a good cosmetic result. And here's a good example of a nipple sparing mastectomy, a little concavity right here. This gentleman could undergo fatty replacement and to fill that area out if you'd like. And if you notice, if I can get my pointer to work here, come on, pointer, you can barely actually see with his hairy chest his well-healed inframammary incision down here or his well-healed axillary incision up here. So the bottom line was that nipple and areolar sparing mastectomies can be an alternative to total mastectomy with removal of the nipple areolar area or breast conserving treatment for male breast cancers. Bottom line is we should be thinking of our men exactly as the way we think of our women. In this tiny little series, we had no major complications. The patients were all happy with the cosmetic outcomes. And the future direction is obviously organizing and putting together a much larger multi-institutional cohort of patients and developing strict guidelines for these patients as well. Anyway, the poster was extremely well received at the American College of Surgeons meeting just held in San Francisco and was awarded one of the top posters at the meeting. So we're constantly, I guess the message here is, we're constantly trying to shift and change the paradigm of the treatment of all cancer, particularly in breast cancer. Now, it's a fun thing, Peggy, that I added to this year's talk. I went to the Memorial Sloan Kettering site, which also is a leading site in the United States in exercise oncology, to see what they had about exercises for men following mastectomies. And these are some really simple and important things. And I thought they would be fun to share to the group. I've got on the slides where people could go directly themselves to look these up. But the arm and shoulder exercises should include forward and backward rolling of the shoulder, particularly keeping the scapula loose and the pec muscles and what have you. Should include the shoulder wings, adducting the arms out so that we keep the buildup of the deltoid and other muscle groups around there. Circular movements around, backwards and forwards. These are all true for women as well, by the way. And then bringing the scapulas together, really working on the posture, the so-called W exercise is really important to do. And then the back climb, putting the arms back behind the shoulders and also bringing the arms behind the head. In other words, working on the range of motion of the axilla. And you can be doing all these exercises once the drains are out and once your surgeon says, you know, the skin flaps are stuck down well enough. That usually takes about 4 to 6 weeks that you can proceed with this. And singly, I think this is one of the most important exercises, the sidewall crawl. What I have found through the 35 years I focused on patients with breast cancer is they want to keep their arm down like it's almost in a sling, and they really lose that range of motion and can end up with a frozen shoulder. So Peggy, what I wanted to do is to give the group a source, and then the wall climbing is doing the same thing, a source of some really good exercises for people to follow, both men and women. Deep breathing is really helpful to expand the chest area. Scar massage, once things are healing up, is important. And just having a positive attitude about all this is really important. Well, anyway, just for the last couple of minutes, am I doing okay time-wise, Peg? I see a thumbs up. Okay, cool. This is the talk I've shared with you guys in the past, including my distinguished colleagues, Katie Schmidt and Karen Wonders. And I'm just shortening this up tremendously. A lot of people have said to me, Jay Harness, why don't the doctors, the surgical oncologists, the medical oncologists, and the radiation oncologists, why don't they know more about all of this data that has been gathered? If you notice, some of the first clinical trials on exercise with cancer patients, whether it's recreational exercise or organized, gym type exercise, goes back to 1990 and has exploded up through 2023. We've now got over 2,600 randomized clinical trials, so-called RCTs, that have resulted in over 5,000 publications about the value of exercise for cancer patients, whether it's breast cancer, prostate cancer, no matter what it is. The reason that we're oblivious to this data is the fact that it's been shared in the data of the researchers, the PhD researchers, the exercise physiology literature, the kinesiology literature, believe it or not, even the sports medicine literature. So then the question becomes, what in the world, Jay Harness, is exercise oncology, exercise in cancer? Think of it as an adjunctive approach to cancer patients emerging from all these studies that we've talked about. There is absolutely no refuting the moderate to strong evidence that these have had on fatigue, anxiety, depression, quality of life, physical function, sleep, bone health, lymphedema, by the way, really important, as Vanessa talked about in her talk. These programs should be evidence-based with supervised, individualized care done either on-site in a hospital setting or virtually. Since the pandemic, we've done way, way more virtually. And we want this to become a universal standard of adjunctive care worldwide, as it already is in Australia. So what we do is to create, a patient comes in, a patient is referred, and an initial evaluation is done. And out of that, a personalized treatment plan is put together. Now, we are not, I repeat, we're not talking about trying to get people ready for a mini marathon, a 10K, a full marathon, whatever. We're talking about getting people to walk briskly 5 days a week for a half an hour, which will give you 150 minutes a week, for crying out loud. You get outside or in a gym or wherever and walk briskly, your heart rate's going to get up. That's part of what we're talking about. 2 to 3 days a week of resistance training, which you can even do at home with resistance bands or things of that sort. As I'll show you in a minute, men are treated at national accredited programs, National Association of Organized Breast Programs in the United States, as well as the National Comprehensive Cancer Centers around the country. More and more is being put into the standards for both of these and the guidelines for these organizations to have exercise included as a standard. Here's a big number. This is coming from all this clinical research I've been talking about. If we just look at breast cancer survivorship, where somebody is physically active after the diagnosis is made, In breast cancer, we can see a reduction up to around 31% of dying from your breast cancer. Now, obviously, all this is predicated on what the original staging was and what have you. That's a big number. What about recurrence rates? A big number, around 22%. But here's the biggest number of all. When we talk about all-cause mortality, we're talking about dying from things other than your breast cancer, such as heart disease or whatever, a 41% reduction. Here's in the standards for the breast centers around. We should be looking at referrals for exercise program as part of their pre-surgery assessment. The same thing after surgery is done, particularly during chemotherapy. People need chemotherapy. It really helps them get through their chemotherapy well, and particularly on long-term survivorship. Exercise oncology programs should continue for years after the diagnosis, and particularly a good location can be out in fitness centers. And as I've already mentioned, the data is overwhelming about its having a positive impact on the 8 common symptoms that patients have. It actually improves chemotherapy completion rates. We've just talked about recurrence survival rates, all-cause mortality. Hey guys, if you want to talk about something that's low cost, this is about as good as you get for cost effectiveness. And we really want to see it become a worldwide national standard. Finally, for lay people and patients, this is a book I've mentioned before by Katie Schmitz called Moving Through Cancer. There's also a documentary out, a wonderful video that Peggy, I should remind me to share the link with you to that site. Scott Hamill, the world famous skater, narrates it, and it's a beautifully done documentary that's come out. And then finally, as my last slide, I wanted to alert everybody that I've just launched a new website called Cancer Fitness. And the idea here is to enhance not only the quality of life, but the vitality of patients going through their cancer journeys and beyond with exercise. So if you go to www.cancerfitness.org, you'll find the site. I haven't gone public with it yet. The site is there, and I will soon be adding videos and blogs to the site, including hopefully this one as well. So anyway, troops, that's it, Peggy. Brett?
That is beautiful.
Always been a pleasure to be here, guys.
Absolutely. And when you go public, we want to put you as a resource on our website. So
okay.
When you're ready to do that, you just send me that information. Will be amazing. So
okie dokie, guys.
But this is knowledge. Any questions you have for Doc here? Anybody that's on right now?
Don, I noticed you were paying great attention. Any thoughts or questions you've got?
He's got to unmute if he.
Okay, he's got his microphone. I don't know if Gary does.
There you go, Don.
Gary does. Anyway,
yeah, no questions. I appreciate your presentation and the information before about lymphedema and stuff like that. I caused my lymphedema in large extent because I changed a tire right after the surgery, and because they took out 22 lymph nodes. And I thought, oh, well, I'm doing okay. I'll handle this. And I changed the tire, and sure enough, I ended up with lymphedema in my right arm.
Oh, well, you did, but don't
months later.
Yeah, but don't be hard on yourself, Don.
Yeah.
The fact you had those lymph nodes out, and that's when it became clinically apparent to you. Are you under active treatment? Or are you handling it okay?
Well, back then, I had to wear a sleeve and glove for years.
Okay.
But I was able to get it down to doing just self-massage to keep my arm and fingers down, because that's how I noticed it, because my fingers were swollen. I said, what the heck is going on?
Yep.
And then I realized it. Oh, you changed the tire 2 weeks after you got out of surgery.
Come on now. That's when you noticed it, okay?
Yeah.
That combination of 22 lymph nodes and or radiation therapy will do it like greater than 60% of the time, if not higher. Okay?
Yeah, I mean, I just had a tiny little tumor on the edge of my nipple.
Oh, Lordy.
There was no other cancer found until not 2016, when they did some scans for why I couldn't tell temperature with my hand. And it turned out there was breast cancer tumors in my lung.
Oh, Lord. Okay. Well, anyway.
Years later, and then of course that they diagnosed me with metastatic breast cancer then.
Sure.
But it started out, all the scans and everything I had after the surgery showed nothing, no cancer anywhere. It was hiding out somewhere, you know.
Good for you, man.
And it also is positive for estrogen. It loves estrogen.
Yeah.
So, which is, I was glad I wasn't a woman, because I probably would have been dead.
All right.
You know.
Well, good for you. Well, thanks for your comments, Don. Appreciate it.
Yeah.
Thank you very much. Well, Peggy, you've got some other speakers, I'm sure. I don't want to take up too much of your time. All right.
Yes.
No, I was Doc with mine. So my lump was right below my right nipple. So do you think? I mean, I don't. If I remember correctly, I don't believe it was. I didn't have like much lymph node involvement at all and stuff. Would I've been able to have the sparing or no?
Yeah, I remember, Brent. Here's the story. That areola, even though it's darkly pigmented, is just skin.
Mm-hmm.
The nipple obviously comes up through it, but it ends up that the ducts that are in the nipple rarely develop cancer themselves. It's in the ductal system below that. And so the answer is yes, sir, you probably could have. Remember, this is another paradigm shift to get breast surgeons like myself thinking, wait a minute, we don't see many men with breast cancer. Obviously, it makes up under 5% of all cancers in men. And so fortunately for us, you guys are a rarity. But we've historically thought that we've had to remove the nipple areolar complex and haven't put in our brain, hey, the nipple and areola is just another margin. And as long as it doesn't have tumor invading it or on it, we can save it. So my guesstimate would be, Brett, you probably could have had that done, okay?
Only 14 years late. No, no, but thank you. Thank you, Doc, for everything that you do. And at least changing the mindset, because yes, we see along the ways that it's just, you know, when I was diagnosed, it was pretty much just told, well, the standard of care for women is mastectomy, and this is how we're going to do it, and there's no other way around it type thing. I appreciate the effort and looking at different ways to treat it.
Yeah, you bet. One of my favorite expressions, Brett, is that we're doing more with less. All right.
That's true. That's what you got to do sometimes. So I appreciate it.
All right, you all. Well, listen, it's really a privilege to see
Tommy,
you.
you got one more question?
Yeah, I got one comment. 2 years later, the VA finally went into doing what you were talking about with the resistance band.
Oh, great.
So your information's slowly getting out there, but yeah, I'm in the same condition with Brett, but I had a double mastectomy and the cancer was right underneath the nipple.
Yeah.
And they're like, since you're not hereditary and it's military related, they recommended I go ahead and do the mastectomy on the other side, and they left the nipple. So.
Yep. Well, but again, it's all evolving, and all I can say is stay tuned. This whole thing about exercise, 90% of my cancer surgeons, medical oncologists, radiation oncologists simply aren't aware of the science that's here and all the benefits. So that's part, as I continue to wrap up my life and career, that's part of my job, is to inform them. Okay.
Well, it's getting out there slowly.
Yeah, you bet. Hey, Thomas, thanks for your comments. Really appreciate it.
You're doing an amazing job, Dr. J. We can't thank you enough for all your knowledge. And if anyone has any questions or whatever, would I be able to share your email with them?
Yes, absolutely. It's an easy email. It's the letter J, the letter K, then harness, like you put on a horse, HARNESS @gmail.com. So JKHARNESS@.com.
That'll be awesome. And then I'll connect you with somebody that has a question, and I'll introduce you to through email. And that'll be awesome. You are so wonderful. We can't thank you enough for
my
participating.
Privilege. Total
knowledge is power, and you've got lots of it.
Thanks so much, guys.
Bless.
Take care.
Have a wonderful holiday.
You bet. Same to you. Thanks.
Bye-bye.
Bye-bye.